want to thank Professors Yellen and Drucker for organizing this symposium and including me in the program. It's a pleasure to be part of these At the Limit conferences. My name is Mansoor Husain, and I'm a cardiologist, professor of medicine at the University of Toronto, and executive director of the Ted Rogers Center for Heart Research. I've been asked today to deliver my remarks on the clinical benefit of modern therapy for type 2 diabetes, with a specific focus on GLP-1 analogues. Here are my disclosures. Well, we know that diabetes and cardiovascular disease are intimately related. What are the data that we can look at in the modern era to sort of show us the relevance of this relationship? Well, on the left-hand side of this slide, you're seeing that data from the United States, where the adult population in 1990 numbered about 178 million, and in 2010 numbered about 226 million. And as you can see, the y-axis of the plot is the incidence per 10,000 overall adult individuals. And the curves are acute myocardial infarction, stroke, amputation, and end-stage renal disease, well-known complications of cardiovascular disease in patients with type 2 diabetes. But these are the event rates in the overall population. When we look at the event rates on the right-hand side in patients with type 2 diabetes, we observe first that there's been a good news story, and that is the declining incidence of myocardial infarction, stroke, and to a lesser extent, amputation, with a flat line for end-stage renal disease. The bad news is the number of diabetics in 1990 were 6.5 million, and in 2010 are 3 times as many. And the other bad news is, look at the y-axis. Between 25 to 150 events per 10,000 of these 4 serious complications, compared to the general population, many-fold higher risk of these events in patients with type 2 diabetes. And it's not just in the United States. In these almost 500,000 patients with type 2 diabetes in the Swedish National Diabetes Register, you'll see over a 15-year span a declining incidence in the line in yellow in people without diabetes, but the line in red are individuals with diabetes. The mortality rate remains almost 2-fold higher. And we know from Kosik-Ray's meta-analysis about 10 years ago that aggressive treatment of type 2 diabetes and other risk factors in patients with type 2 diabetes have variable effects. As this plot will show you, reductions in blood pressure and reductions in LDL cholesterol are better able to reduce cardiovascular events in individuals with type 2 diabetes than reductions in A1C. But these are data from 2009. Looking at those intensive glucose lowering trials that were done in the preceding years. And they used traditional glucose lowering treatments: insulin, metformin, sulfonylureas, PPAR gamma agonists, and just the beginnings of DPP-4 inhibitors. My colleagues here in Toronto, J. Udell et al., published a lovely paper, again, about 6 years ago, again examining these same data about treatment of diabetes. And what they looked at in 14 trials with 95,000 patients with about 4.5 years of follow-up is that aggressive treatment of diabetes in terms of reducing blood sugar does have a small effect on major adverse cardiovascular events and even myocardial infarction, single-digit levels of reduction. But what they observed was a cost, and that was an increased incidence of heart failure. And the conclusion of their study was that this was perhaps driven by some of the drugs that were being used. It seemed to be more a consequence of the PPAR gamma agonists or the TZDs, to a lesser extent DPP-4 inhibitors, but perhaps also insulin. And they concluded that it depended on how you lowered glucose, whether you had benefit or whether you had an increased risk of heart failure. And they were speculating that weight gain, the number they attached was about a 7% increase in heart failure for every kilogram increase in weight gain. And weight gain is really important. In the Look Ahead study, which is a fascinating study, where about 4,500 patients were randomized either to an intensive diabetes intervention or diabetes support and education. And the intensive overall study was neutral. But if you look at the people who responded, the weight loss responders in the Look Ahead study, they actually had significant 21 and 24% reductions in the primary and secondary outcomes, which were all cardiovascular, suggesting that now just losing weight would have cardiovascular benefit. And of course, these two landmark studies, EMPA-REG outcome and LEADER, published within months of each other in 2015 and 2016, really changed the landscape of how we approach the treatment of diabetes. You now have drugs that reduce major adverse cardiovascular events with slightly different time sequence. In EMPA-REG outcome, the curves diverge very early. And in LEADER, with the GLP-1 agonist liraglutide, the curves take a bit longer to diverge, perhaps by about 12 months. But the end result was a 14% and 13% reduction in cardiovascular events. Finally, treatments for type 2 diabetes that were reducing cardiovascular events. There have been many studies that have looked at what the mechanisms might be. But this study by Nock and colleagues summarized with short-acting and long-acting GLP-1 agonists, consistent reductions in A1C and body weight, small but significant reductions in blood pressure and lipids, with this small increase in heart rate. The overall summary is A1Cs can drop by around 1 to 1.5%, weight by 3 to 4 kilograms, systolic blood pressure 3 to 6 millimeters of mercury, and small lipid changes, but all moving in the right direction. SGLT2 inhibitors also have many of these benefits. I would argue the magnitude of the A1C and weight benefit is less than GLP-1 agonists, blood pressure about the same, likely through their effects on natriuresis and osmotic diuresis, but the LDL cholesterol tends to move in the opposite direction. So now these drugs, as shown in their individual two studies I've shown you, I would expect have consistent reductions in cardiovascular events. Do we see that? Indeed we do. In this meta-analysis by Darren McGuire, published last year, looking at the patients with type 2 diabetes at high risk of cardiovascular events treated with various SGLT2 inhibitors compared to placebo, there's pretty consistent effects. The magnitude of that benefit in 47,000 patients overall was about a 10% reduction in the three-component MACE of CV death, MI, and stroke. If I dive into CV death alone, that benefit is 15%. And of course, the major benefit of SGLT2 inhibitors is in the reduction of hospitalizations for heart failure. A very robust, very consistent, over 30% reductions. So much so that this class of drug is now being used for the treatment of heart failure, even in the absence of diabetes. What about the GLP-1 receptor agonist, which is the focus of my presentation? Well, there have been 7 cardiovascular outcome studies, and they are shown here in this meta-analysis by Christensen and colleagues. If we look close at this data, the overall number is a 13% reduction in the three-component MACE, CV death, MI, and stroke in 56,000 patients overall, with reasonable consistency. If I look at some of the other endpoints, components of MACE, CV death, was a 12% reduction. Hospitalization for heart failure is fortunately moving in the right direction. It's a 9% reduction, but nowhere near the effects that we see with SGLT2 inhibitors. If we now look at those GLP-1 receptor agonists that are based on the human molecule, as opposed to 2, lixisenatide and exenatide once weekly, that are based on the lizard exenatide molecule, you see that there are about 35,000 patients in these studies with a 17% reduction in three-component MACE. I want to pause and step back and look at how consistent these studies were by starting with their baseline characteristics. All of them are looking at patients' mean age in the 60s. All of them, the mean BMI was in the obese range. The female sex varied. So for example, the Rewind study is particularly interesting. It had the most women, and it also had the lowest background history of cardiovascular disease. 70% of the patients in the Rewind study did not have a background history of cardiovascular disease, the lowest background incidence of heart failure at baseline. The A1Cs were pretty similar in these studies, but did range from a low of 7.3 in Rewind to a high of 8.7 in several of the studies. You'll notice the systolic blood pressures were between 129 to 137. And the eGFRs were pretty similar, a low of 74 to a high of 80. And the two semaglutide studies are lumped together here just to show how consistent they are, the longest durations of diabetes, 14 and 15 years respectively. And both of these, of course, are testing the molecule semaglutide here subcutaneously and here orally. And more about this oral study later. Let's look at Rewind first. This is almost 10,000 patients with type 2 diabetes over the age of 50, and there was no a priori statement of whether they had to have cardiovascular disease or just risk factors. It turned out that it was, as I mentioned, 70% just had risk factors. Randomized to once weekly dulaglutide 1.5 milligram weekly versus placebo. This is one of our longest durations, CVOT, 5.5-year median follow-up, a very high retention vital status known, very high adherence to the drug. And here are the results of the primary outcome. A 12% reduction, statistically significant, in the three component MACE, MI, stroke, and CV death. When you break it down in this large, long duration follow-up study, actually CV death, all-cause death, and non-fatal MI were moving in the right direction, but not individually statistically significant. Non-fatal stroke, on the other hand, had a 24% reduction that by itself was statistically significant and really drove the overall reduction. How well did dulaglutide control blood sugar and weight? Well, here you'll see the end treatment difference was only 0.6% A1C. And I would argue this is not likely to be the explanation for the cardiovascular benefit. The difference in weight was again in the right direction, but only 1.5 kilograms over 5 years of treatment. Significant, but not an enormous weight reduction. Again, probably effects beyond just weight reduction in A1C to explain the benefits, particularly in an outcome like stroke. What about blood pressure? Well, really quite modest. The end treatment difference was less than 2 millimeters of mercury, and the heart rate was, as has been seen in all the GLP-1 trials, about a 2 beats per minute increase in patients randomized to dulaglutide. Pioneer 6 is quite the polar opposite. This is now the shortest duration of the cardiovascular outcome studies with GLP-1 agonists. In this case, the first orally active agent, where patients were randomized to receive oral semaglutide 14 milligram once daily versus placebo. The dose was built up starting from 3 to 7 to then 14 milligrams. But this was a safety study with a very small number of events by design, at which point follow-up was terminated. As such, the median duration was very short, just under 16 months, and there were only 1,600 patients in each arm. But you'll appreciate here a 4.8 versus 3.8 event rate, 21% relative risk reduction in the three-component MACE that failed to reach statistical significance, given the total number of events was only 137. A very well-conducted study as well. And what about these various components? Well, this study, the benefit was really driven by a remarkable reduction in CV death, a 50% reduction in CV death and all-cause death, but I would caution too few events to really draw any more conclusions. How did oral GLP-1 receptor agonist semaglutide do in terms of blood sugar reduction? So again, a shorter duration follow-up, but a 0.7% difference between placebo and oral semaglutide. And the weight, however, was a 3.4 kilogram difference in patients assigned to oral semaglutide, lost a mean of 4.2 kilograms versus their baseline weight. And what about blood pressure and pulse? Again, a 3 millimeter reduction in systolic blood pressure, really no consequential change in diastolic blood pressure, and a 4 beat per minute increase in heart rate, as has been seen with all GLP-1 receptor agonists. Let me turn to the particular component of stroke. In the analysis by Christensen et al., looking at non-fatal and fatal stroke put together in all 7 of the GLP-1 receptor agonist cardiovascular outcome trials, the meta-analysis shows a 16% reduction in stroke. And this, in comparison to what I've shown you previously, MACE is 12%, CV death is 12%, and hospitalization for heart failure is 9%. It really does show that, like REWIND, and quite consistently amongst the studies, there really appears to be an effect on stroke. What about subgroups? I haven't talked a lot about subgroups, but this meta-analysis gives us, with 56,000 patients, an opportunity to look at the consistency across various subgroups. And you'll appreciate all the point estimates are on the correct side of unity. I'll highlight just a couple. One is this comment I made earlier about human GLP-1 homology versus non-human. This did not reach a p-value of significance for interaction, but it was 0.06, suggesting that the more human homologous GLP-1 perhaps have better benefit. And the other one I want to comment on is this: in the presence or absence of established CVD. I mentioned that REWIND had the most patients without established CVD, but many of the studies had fixed proportions of patients with cardiovascular risk factors only. And again, the p-value does not show significance for interaction. Both point estimates are on the correct side of unity, but it does raise the question of, should we be restricting treatment to people with established CVD, or should we be using these drugs earlier? To answer this question, we recently did a post-hoc analysis of the semaglutide data set, including both the glycemic efficacy trials and the cardiovascular outcome trials with both oral and subcutaneous semaglutide. The molecule is the same. The bioavailability varies when you give it orally once daily versus subcutaneously once weekly, but we see rather consistent effects. The total number of events remains small in these almost 10,500 patients that received semaglutide versus comparators. Because we use glycemic efficacy trials, which are large numbers of patients, but of short duration, and they're not the patients at high cardiovascular risk. These are patients often with only a few years of diabetes, and they're being used to test glycemic efficacy. So you'll appreciate the number of cardiovascular events in that group were rather small, and there were active comparators. But when we do this analysis and we use the leader data set to model cardiovascular risk and plot on the x-axis every patient's cardiovascular risk score, and then the hazard ratio favoring semaglutide or favoring comparator with unity shown by this dashed line here for the 3 components of the endpoint, what this analysis actually shows is just as much benefit, in fact, arguably greater benefit with greater reductions in hazard ratio for CV death, non-fatal MI, and non-fatal stroke in people at lowest risk of CVD, suggesting that there may be benefit. But of course, it's harder to demonstrate. The numbers needed to treat are much larger when you have lower CV risk than the numbers needed to treat when you have high CV risk. So where does this leave us? Well, as this busy slide will show from the joint statement put out by the European Association for the Study of Diabetes and the European Society of Cardiology, that if patients are drug naive with type 2 diabetes, first-time diagnosis, but have established atherosclerotic cardiovascular disease or are at high or very high risk of that disease, for example, have evidence of target organ damage or multiple risk factors, if the answer to that question is yes, they really should be treated with one of these two classes I've discussed today, an SGLT2 inhibitor or a GLP-1 receptor agonist. If the answer to that question is no, then you can follow the usual cascade of monotherapy and then accelerate care based on A1C responses. For us simple cardiologists, because all of our patients are in this group, it really comes down to preferentially selecting agents that have benefits on cardiovascular outcomes. The other statement, which is very important, is that if they now are already on metformin or other background therapy for type 2 diabetes, and again you ask the same question, do they have cardiovascular disease or are they at very high risk of cardiovascular disease? If the answer to that is yes, again we really should be using an SGLT2 inhibitor or a GLP-1 receptor agonist, but the major difference is this should be done irrespective of hemoglobin A1c. And on this side of the Atlantic, the American Diabetes Association has also come out with a very similar statement last year that this should now be the two classes of agents prescribed independent of A1C in type 2 diabetics with evidence of background cardiovascular disease. Now, I haven't talked a lot about adverse events and adherence or discontinuation, and I thought it's worthwhile doing that. I've organized those cardiovascular outcome trials with GLP-1 here in red, and as exemplars, I've used 3 cardiovascular outcome trials with the SGLT2 inhibitors. Here are the daily subcutaneous, once daily injections. Here are the weekly GLP-1 subcutaneous injections, and now we have a daily oral with Pioneer 6 and oral semaglutide. And as you can appreciate, the exposures during these cardiovascular outcome trials varied from as short as 1.3 years with Pioneer 6 to as long as 5.4 years with Rewind, as I've shown you. And the drug was discontinued in these studies from a low of 12% in the shortest duration study, so time is a factor, to a high of 43% in the Excel study. And if you actually look at which studies were positive and which studies were negative, it actually raises the question as to whether Excel might have in part been because there was not as much compliance and higher rates of discontinuation of use of exenatide. But if you compare both injectable and of course oral now GLP-1 with the discontinuation rates of the SGLT2 inhibitors with similar durations of follow-up, they're actually pretty similar. So it's not that one class is easier to use or with higher adherence than the other. So I'll end with this summary slide. High rates of cardiovascular disease remain a major burden in patients with type 2 diabetes. The cardiovascular outcome trials of GLP-1 receptor agonists in type 2 diabetes support the use of this class in patients with or at high risk of cardiovascular disease. And this is really now independent of what their blood sugar is. One of the more consistent and robust benefits of GLP-1 receptor agonists appear to be on stroke. And I think we'll learn more about this. In fact, there are now studies underway where GLP-1 receptor agonist is simply being used in people at high risk of cardiovascular disease with being overweight or obese. In other words, independent of diabetes. So we have more to learn from this field. Thank you very much.